in 3, 2, 1. We are live, ma'am. Please start.
Okay, good evening, Keltis. So it's a great pleasure to welcome you. This meeting is Oncology Cancer Treatment Updates 2023. So we can discuss today on about the lung cancer, and I would like to invite Dr. Arpit Jain sir. He is a consultant medical oncology, Rajiv Gandhi Cancer, New Delhi. So it's over to you, sir.
Thank you. Thank you. Good evening, dear esteemed attendees. It is with great pleasure and anticipation that I welcome you to our seminar on the latest update in the field of lung cancer. As we all know that lung cancer remains to be a formidable disease, and through collaboration, education, and sharing cutting edge research, we can uh, prevent and can better manage these challenges. Over the course of this seminar, we will discuss various aspects of the management of the lung cancers. I encourage you all to be actively participate and can ask questions with the dear faculty also. So with this, without further ado, I would like to invite my dear colleague, Dr. Bhushan sir. He is a resident at Rajiv Gandhi Cancer Institute and Research Center, Delhi. He will be discussing the role of the osimertinib in the first line management of the NSCLC lung cancer. Over to you, sir.
Sir, can
Uh,
Dr. Satyanarayana,
Hello.
sir? Yeah, can we run from our side, sir?
Yes, please.
Tech support, please. Dr. Bhushan PPT slides and support, sir.
Yes, ma'am.
Good evening. Good evening, everyone. So I'll be discussing the my topic is decoding treatment options for EGFR mutant non-small cell lung carcinomas. Next slide, please. So if you look at the worldwide data for all the cancers, the number of cases, new cases in 2020 for both sexes in all ages, we can see the lung cancer contributed for 11.4% of the cases, while the number of deaths in 2020 in both the sexes and all the ages, the lung cancer contribution was about 18%. Next slide, please. So, in both sexes combined, lung cancer is the second most commonly diagnosed cancer, about 11.4% of the total cases. It is the leading cause of cancer deaths. About 18% of the total cancer deaths are the underlying cause is lung cancer. Next slide, please. The parameters which determine the choice of first line treatment in the advanced EGFR mutated non-small cell lung cancer includes progression-free survival, overall response rate, and the presence of brain metastasis, safety and toxicity profile, quality of life, and the patient's receiving subsequent therapy upon progression. So the osimertinib has provided unprecedented improvement in the PFS, which was validated in the FLORA trial. So as we can see in this slide, the median PFS in the experimental arm in the various arms, various trials, the In the IPAS with the gefitinib, median PFS was 9.5 months. Then for erlotinib in the optimal trial, it was 13.1 months. Then afatinib, the median PFS was 11 months. With decomatinib in the Archer trial, the median PFS in the experimental arm was 14.7 months. And the maximum PFS benefit was seen in the osimertinib in the Flora trial. So, next slide, please. This slide is showing the progression-free survival curves with respect to the afatinib versus gefitinib, and we can see the curves start separating at around 12 months. This Lux Lung 7 trial, which compared afatinib with gefitinib, it included the patients who had stable brain metastasis. There were 16% patients who had stable brain metastasis. Then in the Archer trial, which compared dacometinib with gefitinib, here again the patients who received dacometinib, they had a PFS of around 14.7 months, which was much better than the 9.2 months median PFS with gefitinib. And the curves start separating after about 6 months of the therapy. But in this trial, all the patients who had brain metastasis, they were excluded. Now, coming to the Flora trial, which led to the validation of osimertinib versus standard of choice, we can see that the curve starts separating immediately at the start of the treatment only. And this trial also, the patients who had brain metastasis, a stable brain metastasis, they were included, and they comprised about 90% of the patient population. The median PFS in the osimertinib arm was 18.9 months versus the standard of choice 10.2 months. But here again, we should take it with a pinch of salt, because this is a cross trial comparison without any head-to-head comparative analysis. Next slide, please. So this we have discussed. The early separation of PFS curves is shown by osimertinib only out of all these TKIs. If we talk about the overall response rate in the Lux Lung 7 trial, with the afatinib, the overall response rates were of the order of 70%. And with gefitinib, it was 56%. The p-value was 0.0083. And the median duration of response in afatinib arm was around 10 months as compared to 8.4 months in the gefitinib arm. Then coming to the Archer's trial, which compared dacometinib versus gefitinib, we can see that here also the overall response rate was around 75% with dacometinib compared with 72% with gefitinib, while the median duration of response in months was 14.8 months with dacometinib versus 8.3 months with the gefitinib. Now, in the Flora trial, the overall response rate with osimertinib has been highest of the order of 80% as compared to the EGFR TKI comparator, which was 76%. And if we look at the types of responses, there were the 7 patients had complete response. Then 216 patients had partial response, that is about 77% of the patients. Then around 17% of the patients had stable disease. Only 1%, that is 3 patients, they progressed, and rest, some of the patients, they were not evaluable. So we can see that the osimertinib has provided the maximum benefit in terms of the overall response rate. But again, here also, because this is a cross-trial comparison, there was no head-to-head comparison. So this data should be analyzed very cautiously. Next slide, please. With this, we have discussed that osimertinib has shown the highest overall response rate and the median duration of response among all the available TKIs, EGFR TKIs. This slide is showing the overall survival curves for the of the final analysis for the osimertinib versus the comparator VEGFR TKI. And we can see the as we have discussed earlier, even the overall survival curve, they start separating very early at the start of the treatment. And the median overall survival was more than 3 years. The osimertinib patients were more likely to be alive at second and third year landmarks. So this was the first time an EGFR TKI benefit in terms of PFS translated into significant overall survival benefit also, because the earlier TKIs, first generation and the second generation TKIs, they although provided PFS benefit, but it failed to translate into the overall survival benefit. Next slide, please. So this is what we have discussed, the Lux Lung 7 trial and the Archer trial. Here we can see that afatinib, it failed to improve the overall survival versus gefitinib in the Lux Lung 7 trial. And in the Archer trial, because gatekeeping procedure, hierarchical gatekeeping procedure were used for hypothesis testing. Here, the overall response rate was not statistically significant, because of which the formal statistical hypothesis testing for overall survival was not conducted. It was not possible. Next slide, please. So this is the Canadian consensus. The phase 3 Archer trial excluded the patients with the brain metastasis, and it reported numeric improvement in overall survival of 34.1 months for decometinib compared with 26.8 months for the gefitinib arm. But basically, because of this stratified statistical design, the overall survival could not be commented upon in this trial. Although it provided a significant benefit in terms of the median progression-free survival. Next slide, please. Now, if we talk about the osimertinib, about 28% of the patients were found to be still receiving osimertinib at 3 years, which was 3 times more than the patients in the comparative arm. We can see at 36 months, 28% of the patients were still receiving osimertinib, and 22% versus 5% of the patients were still on treatment at the data cutoff. Next slide, please. So, in FLORA trial, the osimertinib demonstrated a superior systemic PFS benefit regardless of the CNS disease. That is the extracranial PFS benefit, regardless of the CNS disease status at the study entry versus the EGFR TKI comparator. So this is the slide which is showing that the progression-free survival in those patients in whom we the brain metastasis, who had known brain metastasis or treated brain metastasis, even those patients derived benefit from osimertinib, and the systemic PFS, that is extracranial PFS, was better. And in the second subgroup, those patients where there was no documentation of any brain mets or the status was unknown, here also the osimertinib provided a PFS benefit with the hazard ratio that was less than unity. The CNS progression events occurred in 17 patients, which amounted to 66% of the patient population, versus 42 patients, which amounted to 15% of the patients receiving. So in the osimertinib arm, the CNS progression events were much less, 6% versus 15% in the standard of care. Next slide, please. Not talking about the intracranial, that is the CNS progression-free survival. This is the CNS full analysis set. And here also we can see that among the 61 patients who received osimertinib and had intracranial disease, there was a progression-free PFS benefit. And at a median follow-up of 12 It was 12.4 months in the osimertinib versus 7 months in the standard of care. So the CNS PFS was also statistically significant with osimertinib versus the comparator. Next slide. Now, this slide is showing the CNS response to the first line if the osimertinib is used in the first line setting with in the patients who have EGFR mutated advanced non-small cell lung cancer and CNS metastases. So here we can see that the response rate was 66 versus 43%, and the here the authors have compared with gefitinib or erlotinib, while in the afatinib and the decomatinib they haven't reported the response rate in the CNS, while the response rate, systemic response rate, only they have reported. And this trial with decomatinib, here the brain metastasis was excluded, so the data from this trial was not available. Next slide, please. So now coming to the safety profile, the grade 3, grade 4 adverse events with decomatinib were reported in 63% of the patients in the Archer trial, while more grade 3 or more than grade 3 adverse events for afatinib were reported in 31% of the patients in the Lux Lung 7 trial. If we talk about the side effects, the adverse events of the osimertinib, grade 3 or more adverse events with osimertinib were reported only in 18% of the patients in the FLORA trial, and most commonly these adverse events were the dermatitis acneiformis, diarrhea, maculopapular rash, that is skin manifestations, then fatigue, and another very important side effect is paronychia. Next slide. So this slide is summarizing the grade 3 and grade 4 toxicity with second and third generation EGFR TKIs. So we can see that with osimertinib in FLORA trial, there were only 1%, less than 1% grade 3 and grade 4 toxicity, skin toxicity. Then paronychia, grade 3 and grade 4, it was also less than 1%. And diarrhea, 2%, grade 3 and grade 4 diarrhea was 2%. Then stomatitis, it was also very less than 1%. While with the afatinib, there were skin reactions, grade 3 and grade 4 skin reactions, skin toxicity was also higher, of the order of 9%. With decomatinib, it was 14%. Then paronychia was also, it was highest with decomatinib. Then diarrhea, with afatinib, it was seen in 13%, grade 3 and grade 4 diarrhea, and with decomatinib in 8%. So the toxicity profile, the adverse toxicity profile of the osimertinib in FLORA trial was shown to be very favorable. Next slide. Now, what about the dose reduction in EGFR TKIs when the second generation EGFR TKIs, afatinib and decotinib, have been shown to be frequently cause adverse events that further necessitate dose reduction, as we have seen in the previous slide. In the Lux Lung 7 trial, adverse events leading to dose reductions were more frequent in patients receiving afatinib as compared to the gefitinib, and the difference was also very significant, 42%, around 42% discontinuation with afatinib versus only 1.9% in the gefitinib. Then in the Archer trial, there were more dose reductions in patients in the decomatinib group with the gefitinib group, 67% versus 8%. While in the FLORA trial, the frequency of dose reduction was almost similar between the osimertinib and the SOC, 5% and 4% respectively. Next slide. So now this slide is displaying the quality of life data. The global quality of life was maintained in the decomatinib group. It was maintained. It was like stable. But in the decomatinib group, while in the Jeftinib group, they have reported significant improvement in the quality of life. And in the FLORA trial, the global quality of life has improved from baseline in both osimertinib as well as in the EGFR TKI comparative groups. And there was no clinically relevant difference between the two groups. And the factors considered for assessing the global quality of life were cough, improvement in terms of cough, dyspnea, pain in chest, loss of appetite, and fatigue. So all of these factors were not different in TKI comparator group, and they showed an overall improvement in terms of these factors in the osimertinib with osimertinib, which was non-inferior to the comparator arm. Next slide. Now, about only one third of all the EGFR mutated patients treated with first or second generation EGFR TKI are able to receive second line osimertinib. Like this slide is showing that if around the patients who have EGFR mutated non-small cell lung carcinoma who have started on these gefitinib, erlotinib, or afatinib, first or second generation TKIs, then about 73 to 77% patients they will receive second line therapy, and some of the patients will die during the first line or receive only palliative care on progression because no T790M test for the resistance is done. Then out of these 73 to 77% of the patients, again 60 to 67% patients, they will receive a valid T790M test result, while the rest of the patients, they either because of the lack of the tissue biopsy or insufficient tissue from the earlier biopsy, they'll get a false negative test or some invalid results or logistics issues, because of which this T790M test could not be performed. And out of these patients who receive 60 to 76% of the patient who receive valid T790M test result, out of these patients, 50% of the patients, those who are having a valid test result, they will come out to be T790M positive, and the rest of the patients they will again exit as T790M negative. And so finally, if we start with the 10 patients, only 3 patients will be eligible for the second line osimertinib. So 7 out of 10 patients who are started on first or second generation EGFR TKI will not be able to receive osimertinib in the second line. And as of now, it is not possible to predict who will develop T790M resistance. Next slide, please. Again, as we have seen, the access to second line therapy is will be available for only one third of the patients, and most of the patients they will not receive second line therapy because of the logistics and various other factors. Next slide. So now, what is the real-world evidence of T790 mutation after afatinib? In a Japanese study, 43% patients out of total 37 patients acquired T790M after first-line afatinib. In the Taiwanese studies, 48% of the 42 patients who were rebiopsied after receiving afatinib and progression on afatinib, they had acquired T790M mutation. So similarly, in another Taiwanese study for 28 afatinib treated patients, T790M was identified in 32% of the patients. So next slide. So less than 50% of the patients put on afatinib acquired T790M mutation, and rest 50% will not require. Next. So how to sequence the EGFR TKIs? Starting with the prior generation, that is first line and first generation and second line EGFR TKIs, and then treating those patients who develop EGFR T790M with osimertinib. Should we follow this strategy? This is not optimal clinical care because we are not smart enough to figure out who will get EGFR TF70 mutation, and not everyone will be well enough to receive additional treatment. 30% of the patients did not receive any subsequent therapy, as we have seen earlier. Sometimes tissue and liquid biopsies are not always successful. And osimertinib is associated with a significant survival benefit as first if given in first line setting. Next. Next, please. So there are some uncontrollable factors also when sequencing the EGFR TKIs, which need to be taken care of, like toxicity of two drugs, occurrence of T790 mutation, sites of progression, then concurrent morbidity, and patient's choice. Next. So now we'll talk about some real-world studies with first-line osimertinib in EGFR mutated non-small cell lung cancers. Next. So the flower study, which stands for the first line osimertinib in the real world. Here, the real world perspective, it was a real world perspective observational study. 9 centers across Italy recruited about 126 patients. The 45 were male, 81 were female from June 2018 to September 2020. So these patients who had metastatic or advanced EGFR mutated non-small cell lung cancer, they received osimertinib in the first line. All the patients were of white race. The median age was around 68 years. 120 patients were having adenocarcinoma, while 3 had squamous cell carcinoma.
Bhushan sir,
Sir.
sorry for interrupting. I think we
Yes.
can discuss these real world data in the subsequent talk also.
Okay, sir.
So I think you can conclude your talk.
Okay, sir. Okay. So last slide, please. So to summarize,
Previous slide.
previous
Yes.
one. So to conclude, osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. The median overall survival benefit of greater than 3 years sets a new benchmark for osimertinib. Flora is the first time an EGFR TKI has translated PFS into overall survival benefit. And nearly 30% of the patients remained on osimertinib at 3 years. Osimertinib is the only drug which can be given in patients with brain metastasis and T790M mutations. Osimertinib, the toxicity profile is also very favorable, and sequencing can't be considered the best strategy, as almost 70% of the patients will not remain eligible to receive osimertinib in the second line. So these data, it confirms the osimertinib as the first line standard of care in the metastatic EGFR mutated non-small cell lung cancer. Thank you.
Thank you, Bhushan sir. You have very well elaborated the therapeutic landscape of the treatment of the EGFR mutated NSCLC patients. And again, this with the data from the landmark Flora trial again shows that osimertinib has an edge in relation to the safety and the efficacy both the other EGFR TKI agents also. And again, I think the whole of the paradigm of the discussion has been shifted to the management post osimertinib progression. So definitely, I think in next year we will be discussing about how we can manage the patients with after progression on the osimertinib. So thank you. Next, I would like to invite the next speaker, Dr. Satyajit sir. He's a consultant and the unit head at Sri Ram Cancer and Super Specialty Center at Mahatma Gandhi Medical College, Jaipur. He will be discussing the overview of the molecular biomarker testing in lung cancer patients. Dr. Satyajit, sir, over to you.
Sir, make it full screen.
Just wait for a minute. Is it visible?
Yes, sir, it's visible now.
Should I start now?
Yeah, you can
Yes,
start.
yes, sir.
Good evening, all, and thank you, Dr. Apurvan and Dr. Mr. Janaka, for providing me opportunity to present a topic on the molecular biomarker testing in the lung cancer.
वेबिनार ज्वाइन कर लो मेरा लिंक दो लिंक दे दो
सिंपल देना जो वो वाला मुझे
sorry, sir, can please proceed.
The content of this presentation includes lung cancer status in India as per the Globocan data, and the biomarker, how to test biomarker in the NSCLC, and the evolution of the biomarker testing in the NSCLC in the past and the current scenario, with few key takeaways. The burden of the lung cancer in India, Globocan, as per Globocan 2020, as everybody knows, the lung cancer in India, including both sex, it is fourth most common malignancy. And if we talk about the male patients, it is the second most common malignancy after the lip and oral cavity. And or if we talk about incidence, mortality, prevalence overall, then it is the fourth common malignancy. The 50% of the patient with advanced non-squamous NSCLC have driver mutation targetable with few FDA-approved agents or on the basis of the clinical trial. And the most common mutation among lung cancer patients of non-squamous NSCLC, it is KRAS, which is includes 25%, and among KRAS mutation, is the G12C variant is most common found, which are targetable by the newer agents like sotorasib and ongoing trial with adagrasib. And second most common mutation to found, it is EGFR mutation, includes exon 18, 19, 20, and 21, and with a few uncommon mutations that are targetable by the EGFR TKIs. And third most common, ALK rearrangement, which is found in the 4 to 7% of the patients with targetable with first crizotinib, alectinib, ceritinib, lorlatinib, and brigatinib like TKIs. And other, if we talk about specifically about exon 20 insertional mutation, which is very uncommon, with nearly found in 0.1% to 0.4% of the patients, which are targetable by the newer uh, monoclonal antibodies and DPAs like amivantamab and mobocertinib. And other mutations are like MAT skipping mutations or MAT amplifications or HER2 mutation, ROS1, BRAF, RET, and TRAC, TIC3, and MEC. All are targetable by various agents. The importance of the biomarker testing in the NSCLC. The graph showing the showing overall survival among the patients with NSCLC patients driver alteration. Patients, those are driver alteration found but treated with targeted therapy had median OS of the 18.6 months, and with no targeted therapy had median OS of the 11.4 months. There is a significant difference in the overall survival. Those patients with treated with the targeted therapy. And there are various guidelines which recommends which test to do or which test not to do. As we all usually follow the NCCN guidelines, which recommends all testing like EGFR, L-CROSS, BRAF, MET exon 14 skipping mutation, red gene fusion, and TRK gene fusion, and PDL1 expression and the KRAS mutation. Only NCCN and the CAP IACLC AMP recommends the KRAS mutation. As KRAS mutation is very important to detect because of it also shows the prognostic significance also. So, there are various methods of testing on tissue sample in the NSCLC. Now, if you want tissue testing methods includes DNA sequencing, NGS or PCR, or RNA sequencing panel, and IHC or FISH. All had their different importance, and DNA sequencing, NGS and PCR we use to detect for insertion, point mutation, deletion. It detects aberration in the EGFR, KRAS, HERA, HER2, and MET, either single gene or full NGS panel. RNA sequencing panel help to detect fusion abnormality like mainly ALK, ROS, and TRK or RET. ISC, which used to detect protein expression, which detect PDL1, or we can detect ALK or ROS by ISC also, but we have to confirmation by FACE for ROS1. And FACE detects ALK or ROS, which are FACE is highly specialized in the can be faster than the evolution of biomarker test in the NSCLC past and current scenario. The tissue journey we can detect the uh, or we can detect gene assessment on the all the kind of tissue cytology or liquid samples also, either on the resection specimen or excisional biopsy or some small tissue core biopsy. We can detect with the some after taking the fluid from the body and make cell block for further genetic assessment, and the liquid biopsy in the terms of blood or septic fluids. First, to make formalin fixed paraffin amide blocks to go for histology and cytology, and and go for parallel diagnostic by IHC or FIT. To assess the DNA or RNA, we had discussed already within previous slide. No need to, I think, no need to go with this slide. The biopsy has its importance to establish the diagnosis and to determine the specific subtype, histological subtype, and further biomarker testing. In histological subtyping, first we have to define whether it is a small cell or non-small cell. Then in non-small cell, whether it is squamous or non-squamous. For biomarker testing, primary tumor and metastatic lesions are equally suitable, but bone biopsies can be suboptimal due to decalcification or degradation of the DNA. And so liquid biopsy is further another option. The test for EGFR, L cross, and BRAF, and track RET, MET exon 14 in the all non-small cell NSCLC to use broad NGS testing to detect most mutations using least amount of tissue. Because of in lung cancer, tissue is an issue, always an issue. And for squamous NSCLC, consider testing in the young. In squamous histology, if patient is young, never a light smoker, or if biopsy specimen is of mixed histology, then we should consider for all these testing. And all NSCLC patients should get tested with PDL expression via IHC. And completion of the testing within 10 to 14 working days of the biopsy is recommended. So circulating tumor DNA testing has the potential to be applied across all the stages of NSCLC and throughout the treatment pathway. It helpful for diagnosis and the treatment selection, monitoring prognosis, response to treatment, and the prognosis or relapse of the disease. And ctDNA testing overcomes some major challenges associated with the tissue testing, as it is minimally invasive for the patients, allowing for serial biopsy if needed. And the ctDNA has in the bloodstream is comprised of the DNA from all tumor sources in the body and captures both tumor heterogeneity and the tumor changes over the time. So ctDNA may never replace the tissue biopsy entirely, but could have a complementary role to support the treatment selection of the patient with NSCLC. There is a study tracer X study which included 24 early stage NSCLC patients followed longitudinally after resection, and phylogenetically circulating tumor DNA profiling was done. Of 14 patients in those with recurrence has happened, 93%, that is 13 of the 14 patients of recurrent were MRD positive, and the 90% of the patients without recurrence were MRD negative. So the presence of MRD may be used to predict the disease recurrence, and currently MRD cannot be identified using traditional diagnostic methods. For that, ctDNA may be helpful. So comparison of tissue versus liquid biopsy testing. First, we'll talk about tumor tissue, then we'll about liquid biopsy. As tumor tissue sampling is the invasive surgical procedure to obtain the tumor tissue, and so there is this challenge with repeat sampling. is not feasible for each and every patient if there is a lack of tissue, so we can't go for again biopsy. So, and the correlation with histology and cellular phenotype is possible with tumor tissue, and there is a lower tumor cell content acceptable with sensitive techniques, like 1 to 10%, and the tumor tissue uses existing validated tissue processing and handling the procedure in terms of analytical standardizations, and there is a in terms of evidence of clinical utility, we talk the substantial evidence of for initial targeted therapy selection and the subsequent treatment of targeted treatment failure in the advanced NSAID. If we talk about liquid biopsy, it is simple procedure to draw just blood only and minimal invasive. We can go again for repeat sampling. It direct correlation between the ctDNA result and histology is not possible actually. It is more reflective of tumor genomic landscape only, and is very sensitive method required as CTD. Very sensitive method is required as ctDNA may comprise less than 0.1% of the cell-free DNA. And talk about analytical standardization. Standard of the for analytical performance characteristics of cell-free DNA, ctDNA have not been established. So no guideline exists regarding the recommended performance characteristics of the liquid biopsy. Evidence are less, but increasing for initially targeted treatment selection and subsequent treatment after the targeted treatment failure in the advanced NSCLC. Multiple gene involved in the NSCLC. The single gene reflex testing or multiple gene testing. Obviously, it is better to go with multiple gene testing by NGS with single shot. So it is easy to identify all the mutation, whatever the mutation is present by one chance. So and they are easily targetable. What are advantages of the NGS? NGS has the number of advantages over the single gene test, as the number of clinically actionable biomarker has increased. The ability to evaluate all known molecular alteration in a single test has given NGS as a major advantage. Some pros and cons of NGS versus single gene test. The pros are it detects a broad range of molecular alteration in the single sample, and it may identify new marker that could offer additional treatment options for a patient and or provide information to help with the development of new and more effective treatments. The cons of the using NGS versus single gene test are that is highly complex. There is highly complexity of workflow that require experienced personnel, and the advancement in the field of NGS are evolving rapidly. The patient and the clinical community must receive sufficient education in this area. The technique and molecular landscape in the next you'll see. They already, I think, already discussed in various techniques like PCR, NGS, and fission. So we can go. So it is a molecular landscape of non-small cell lung cancer with available treatment options. I am skipping this slide because of these are the only genes and their targetable agents are mentioned here. The EGFR mutation we will discuss one by one every testing. EGFR mutation in the lung adenocarcinoma. The sample type used for EGFR mutation testing, the formalin fixed paraffin embedded sections or frozen or alcohol fixed specimen can be used for PCR based assay, and for cytology, a cell block from the fluid or are filtered over the cell smears. And the table is showing the summary of studies of the concordance of EGFR mutation, the primary versus metastatic. This is a very rare occurrence of the discordance in between EGFR positivity and negativity within the primary tumor and the metastatic experience. EGFR mutation test in the early lung cancer. As in almost Adora trial has already came for this. So consider adding molecular testing for EGFR mutation to be performed in all diagnostic biopsy or post-surgical resection sample to ensure the EGFR mutation results are available for adjuvant treatment decision for the patient in stage 1B2, stage 3A. An advantage of the NGS over PCR. It is in this slide, it is mentioned for the specifically mentioned for the exon 20 insertional mutation. One study showed that for nearly 50% of the EGFR exon 20 insertional mutation identified by the YNGS are missed by the PCR. And out of 17 most common EGFR exon 20 insertional mutation variants, only 4 can be identified by the VCR. So it is better to go with NGS. And ALK rearrangement in the NSCLC. In most cases, ALK ISC is 93 to 100% sensitive and specific and 93 to 100% sensitive and specific as compared to the fish, and the false positivity rate of the 0.1% with the fish. The ISC is less expensive, hence it is more widely used or adopted. Cross rearrangement of the NSCLC. The NSCLC, adenocarcinoma or non-squamous non-smoker with squamous histology, we go for EGFR, ALK or ROS. EGFR to detect with the RT-PCR or NGS plus with or without KRAS, and ALK by ISC or fish. ROS, if done by the ISC, it has to be confirmed by the fish if it comes positive, and vice versa also. So KRAS mutation, it is RAS sends activating signals to a number of cellular pathways involved in the cell proliferation and the survival, including pathways RAS, RAF, MAC, ARC pathway, which help for the, if there is a KRAS mutation, then it will lead to further cell proliferation and the survival of the cancer cells. KRAS mutation is the most common mutation in the lung, adenocarcinoma of lung, nearly 25 to 30%. And the most common of these arise in the codon 12 and 13, with the G12 is the most common variant found in 13% of the patients lung adenocarcinoma. And it is a poor prognostic marker compared to the wild type KRAS. And method of detection, there is no single gene KRAS testing is currently recommended. It should be only performed with multi-gene NGS panels. Targeted therapy, sotorasib is already approved for next line of the for second line onwards treatments in case of KRAS mutated patients. And another drug is adagrasib, which are showing potential have showed potential results in the early phase 2 or phase 3 trial. The acquired resistance to therapy has been observed. All the specific resistance mechanisms are not well understood yet. For BRAF, next to the RAS is RAF, so BRAF inhibitor. BRAF mutation, it is targetable with the BRAF inhibitor. Whenever the BRAF mutation is present, we have to target with both dual agents, BRAF inhibitor plus MEK inhibitors. So RAF kinase is involved in the regulating cell proliferation and the survival by the facilitating the signal transmission between the cell surface and the nucleus. BRAF V600E mutation is present in the more than 50% of the BRAF mutation cases, and it is thought to be more prevalent in the smokers, like RAS mutations, and non-V600E mutations such as V600K, G466V, and G469A are less prevalent and occur in the 17% of the patients with the BRAF mutation. So it is always to be remembered the ending in KRAS it is G12C and BRAF is V600. V600E are the most common types in mutation involved. And overall BRAF mutation occur in the 1 to 5% of the patients with NSCLC, most commonly adenocarcinoma. Again, while NGS is generally used for multiple gene testing, so there is no single gene based. Targeted therapy, already discussed, we should treat with BRAF inhibitor with MEK inhibitor. Currently approved is dabrafenib plus tramadolid. And acquired resistance generally developed by the pathway that bypass the RAF, such as redirection of the cell signaling via the downstream MEK 1 or 2 kinase. Next one is c-MET, MET receptor tyrosine kinase and MET exon 14 skipping mutation. The normal role of MET gene in the embryogenesis and the wound healing. In the cancer, MET exon 14 skipping mutation causes in-frame deletion of the juxtamembrane domain, resulting in the increased stability and the constitutive kinase activation. It is MET exon 14 skipping mutation found in the 3 to 4% of non-squamous cell NSCLC. It is most commonly associated with carcinosarcoma or sarcomatoid cancers in nearly 20 to 30% incidence of the MET exon 14 skipping mutation. And the majority of MET exon 14 skipping mutation can be detected with DNA NGS, but increased sensitivity with RNA NGS. Method of MET exon 14 skipping mutation detection. IHC in fish is not recommended. PCR by the DNA or design dependent, and RNA is technical concern. For NGS, it is RNA is more sensitive to detect the RNA. NGS is more sensitive to detect MET exon 14 skipping mutation. Red gene, red receptor tyrosine kinase and red fusion in the NSCLC. Red gene has normal role in the neural genitourinary development. In case red gene rearrangement give rise to chimeric cytosolic protein with constitutively active red kinase domain. In found in 1 to 2% of the non-squamous NSCLC, and mainly it is found in the papillary thyroid carcinoma, nearly 10 to 20%. The majority of red fusion gene can be detected by DNA NGS, but again fusion, so it is increased sensitivity with the RNA NGS. Method of red fusion detection, ISC. Because ISC and fish has cones in terms of significantly false negativity results. So RNA NGS obtain fusion partner information without intron coverage issue, directly assess the fusion expression. So highly depend, and cones of RNA NGS is highly dependent upon the RNA quality. So poor quality lead to reduce the sensitivity. And according to this pros and cons of all the methods, the RNA NGS it is well recommended for the fusion analysis. The majority of red fusion can be detected with DNA NGS, but has increased sensitivity with the RNA NGS. For Enteric fusion, the options are again IFC, RNA or RNA-based NGS or DNA-based NGS, fish or artificial. It has advantage or disadvantage with each method. And again, we have already discussed that for fusion, it is RNA-based NGS is always more sensitive. And the choice of assay will depend on the institution, resource in the clinical context, reflexing to NGS versus IFC reasonable for NSCLC due to low prevalence of NTRK. The method of enteric TRK fusion detection for ISC, it is found to provide rapid results, detect the transcribed and translated events only, and low cost as single test and widely available. But disadvantage, there is a depletion of the tissue, fusion partner position is unknown and less well validated currently. So for enteric, again it is NGS only, potential for multiplex test, less depletion of the tissue, fusion partner and position are defined, and the RNA NGS is the most sensitive. The HER2 mutation is also known as ERBB2 in 3 to 5% of the NSCLC adeno, mostly includes exon contain frame insertion, and it is mutually exclusive with other mutations mostly seen in the never smokers, and had worse overall survival than other subtype in the lung cancer mutation consortium. In NSCLC, HER2 mutation and amplification must be identified using an NGS DNA panel similar to the breast cancer, and ISC used to assess HER2 overexpression seen in the 59% of the NSCLC cases. HER2 2 or 3 plus is up to 30% of the patients. It was a 2020 treatment paradigm for molecular biomarker positive advanced NSCLC. Advanced NSCLC, if it is EGFR mutation, whether it was most common deletion 19 or L858R, it should be first treated with third generation osimertinib. And it found it is uncommon mutation. Which uncommon mutation is there? Whether it is exon 20 insertional mutation or other uncommon mutation like G719X, L861Q, and L768I. So these uncommon mutations should be treated with afatinib or osimertinib. And for exon 20, it is amivantamab or mobocertinib. For ALK, alectinib and brigatinib, or second generation and third generation ALK TKIs preferred over the first generation TKI. On progression depends on the which previous therapy was used. For us, it is
Satyajit sir, can you conclude your talk in 1 or 2 minutes?
okay. Just 3 or 4 slides. Right? So we should we should treat in first line as per recommendation, and second line for KRAS, and for exon 20 insertion mutation, we use available drugs are approved in only second line. So for PD-L1 overexpression in NSCLC, the PD-L1 antibody clones ISC platform and the scoring system. There are various platforms to detect the PD-L1 22C3, SP2C3, SP142, and 28. For pembrolizumab, it is DECO platform to be used for help from the companion diagnostic type. And these are the different scoring system again shown by slides. And the biomarker for immunotherapy in NSCLC controversial topic. PD-L1 shows current biomarker able to guide immunotherapy. Imperfect PD-L1 negative tumor can still respond, albeit mostly when added to chemotherapy. Synergistic effect is there, query. And TMB, former marker for response, not currently used. Conflicting correlation survival in the checkmate study. For MSI, high and MMR not used or relevant in the lung cancer. Leg 3, possibly related to resistance to immunotherapy being studied. On concluding, biomarker testing in NSCLC has evolved from single gene to multiplex testing, and multidisciplinary meeting help in the better understanding of sample and test requirement. And sample should contain adequate tumor content, at least 10% to prevent delay in the processing. An ideal TAT is 2 weeks, nearly 10 working days for the NGS. And high throughput platforms such as NGS can be used to screen several genes at a time to provide result within the estimated time. Thank you.
Thank you, Dr. Satyajit sir. Such a comprehensive elaboration of the various principles of the molecular and biomarker testing in the lung cancer patients. I have just a small questions from you. So could you please describe your approach for offering the biomarker testing in patients, particularly with early lung cancer patients and also in squamous cell lung cancer patient in your practice? So what all biomarker testing do you offer in such patients?
For early lung cancer, for in setting of adjuvant therapy, osimertinib is already approved. So we used to detect EGFR, and for ALK and PD-L1, second is PD-L1 as adjuvant immunotherapy is also approved. But for ALK, it is not. It is under trial, so we usually not advise only EGFR or PD-L1. And for squamous, if patient is young and non-smoker, then we usually advise for gene panel test.
Yeah. Thank you, sir. So I would like to invite my next speaker, my dear colleague, Dr. Satyanarayan sir. He is a consultant and unit head at Jindal Institute of Medical Science at Hisar in Medical Oncology Department. He will be delivering his lecture on the note on overview of the lung cancer, particularly the demography and the therapeutic landscape. So over to you, sir.
Good evening, Dr. Arpit. So my topic is overview of the lung cancer and landscape of the management of the lung cancer treatment. So the burden of lung cancer in India, as per Globocon 2020, based on both sex, the lung cancer is third most common, which is approximately 5.5, fourth most common, which is 5.5% based on diagnosed in both sexes. So first is breast, second is lip and oral, third is cervix, and fourth is lung cancer. If we will consider the only males based on the Globocon 2020 data, so the second most common in the males as per the Indian demographic details. So as we know, the changes in the lung cancer in the seventh, considering the seventh AJCC versus eighth AJCC. So it was considered as T2B, but now it is considered as T3, which is minimum stage 3A. And if the tumor is more than 7 centimeter, then earlier it was T3 in as per the AJCC 7, and based on AJCC 8, it is T4 now. So minimum stage is 3A. So various investigative tools for staging workup, which is bronchoscopy, CT chest, PET-CT, EBUS and EUS, and mediastinoscopy and MRI brain, and another important test, which is pulmonary function test, if it was not previously done. So the CT versus PET-CT for the staging purpose in stage 3 lung cancer, which is if lymph node size is more than 10 mm along the short axis, it is highly predictor of the malignancy. So considering the CT scan, based on the various reported data, the sensitivity is low sensitivity, which is 55%, and specificity is 81%. While considering the PET-CT compared to the CT scan, the sensitivity is 80 to 90% and specificity is 85 to 95%. So risk factor for the occult N2 metastasis not always detected by the imaging. So based the occult metastasis N2 is depend on the whether tumor location, whether it is peripherally located or centrally located, or based on the tumor size, whether tumor is up to 2 centimeter, then it is possibility of 4.8%, up to 4 centimeter it is 6.5%. Possibility of the occult N2 metastasis, and if tumor is up to 6 centimeter, then possibility is 6.3. If tumor size is more than 6 centimeter, then high probability of occult metastasis is there, so which is 57.1%. So based on the Lee et al., which was reported in the 2007. So another one differentiating feature to find out the occult N2 metastasis, which is the SUV index in the PET-CT. So if it is up to 4 SUV, then the occult metastasis probability is only 1.9%. Otherwise, if it is more than 4, then it is significantly higher, that is 10.5% possibility of the occult N2 metastasis. So if the tumor is central located, size is more than 4 centimeter, and the SUV also more than 4, then we should consider that there is high probability of the occult N2 metastasis, which is not detected by the imaging. So we should consider for the further investigation for the occult metastasis, that is mediastinal staging. If we want to go by the less invasive technique, that is US, or second is EBUS based biopsy. So depends on the whether which lymph node level is suspicious for the N2 involvement. So another one is the invasive, that is mediastinoscopy, that is either conventional or video assisted mediastinal lymph adenectomy, or transcervical mediastinal lymph adenectomy, or that's video assisted thoracic thoracoscopy. So these are the invasive techniques. So based on the mediastinal staging, there are, as we know, that there are 4 nodal stations which are divided in the 5 zones. So depends on the positivity of or suspected N2 level. So we should go through the either EBUS or EUS in minimally invasive technique. And if still the suspicion is there and still high probability of involvement of the lymph node level, then we should go through the invasive or mediastinoscopy is recommended. So when is invasive mediastinal staging should be indicated? If tumor is centrally located, as we have previously discussed, that if tumor size increases, there is probability of occult N2 metastasis, then we should go with the invasive mediastinal staging if tumor size is 3 centimeter. And if there is extensive infiltration of the mediastinum with no extra thoracic disease and or positive N1, then we should go with the invasive mediastinal staging. And if bulky N2 is on CT scan, no need to the confirmation of the invasive staging of the mediastinoscope. And if discrete involvement of the N2, then yes, regardless of PET CT results, we will go without the mediastinal staging. So if normal mediastinal on CT scan, we should go with the PET CT. If PET CT is suggestive or positive, then definitely we should go with the mediastinal staging. And PET CT is also negative, as the CT scan is negative, so we will not do mediastinal staging. So various lymph node accessibility through the various techniques, as we all know that most of the lymph node stations which are addressed through the TEMLA, and less based on the different staging, different procedure we can address, like US based mostly 8 and 9, and EBUS based the 7, 10 and 11 can be addressed. So non-invasive technique have different sensitivity and specificity. So most common, as we already have discussed, that most of the lymph node are addressed through the WETS procedure, and which have highest sensitivity, which is 99%. So considering the diagnostic part, so there is evolution of the therapy in lung cancer. So as we know that 85% of the lung cancer are non-small cell lung cancer, and 15% are small cell lung cancer. Out of the 85%, 25 to 30% squamous, and other are adeno and the large cell type. So out of these, most of the patients present with the metastatic presentation, and 50% of the patient out of these are die within a year. So based on all these and the prognostication, so we know that lung is not considered as a single disease. It is distinct subtype, various characteristic feature. Earlier it was lung cancer. If we will see in a traditional view to the present view, so later on it is divided into non-small cell and small cell. Based on histology, it is squamous, non-squamous, large cell, adenocarcinoma, and further divided. And further, based on molecular profiling, there are, as we know, right now there are approximately 20 molecular pathology, but most common.
Arpit sir, I think he's left the webinar. Yeah.
Yeah, sir rejoined.
Sir,
Yes.
can you please unmute
There
yourself?
was some connection error. So I think Dr. Arpit, can you hear me?
Yes, sir, you are audible. I think you can switch off your video. It would be better.
Yeah.
Yes, sir, you can
So,
continue. Yeah.
so based on the various IHC profile-based diagnosis of the lung cancer, which is adenocarcinoma, which is uh, positive for the nepsin 80% and TDF1 80% positive. There is also chances of positivity of CK7, P63, CK5. So considering the squamous cell carcinoma, which is positive for the P63, P40, and desmo3 and P40, and also sometime 20% patient can positive with the CK7. So considering the neuroendocrine tumor, which can positive or negative for the CK7, and most of the patient who are neuroendocrine, 80% of the small cell patients and 50 to 60% of the large cell neuroendocrine tumor or carcinoids or cancer, which can be positive for the TTF. So after thyroid, there is small cell adenocarcinoma and large cell tumor have positivity for the TTF1. And considering the chromogranin and synaptophysin and CD56, there is at least 2 of them are positive in the neuroendocrine tumors. So advancement in the management of non-small cell lung cancer have improved based on the Nadia et al. The effect of advances in the lung cancer treatment on population mortality. So if we will consider the reported data by the Nadia et al., so the lung cancer specific survival improved from the 26% between 2001 to 2014, which was 26 to 35%. So reduction in the incidence along with the treatment advancement, which was presented by Nadia et al. So what was changed from 2001 to 2002 to the till recent era? Earlier, the treatment was done on histology basis. Now the targeted therapy based. And after the 2014, the checkpoint inhibitors, which is anti-CTLA4 and PD1 and PDL1. So the overall survival, which was improved in the histology based treatment, which was 10 to 12 months. After targeted therapy, which is approximately 4 years, checkpoint inhibitors, which is approximately 3 years, and now the combination of the immunotherapy and targeted therapy along with various anti-angiogenesis agents also are used, which are have better treatment results after the use of anti-angiogenesis. So advancement in the treatment of non-small cell lung cancer, early versus late, targeted and immunotherapy, a significant increase in the both outcome based on the either patient treated with the targeted therapy or immunotherapy. So DFS and PFS both improved, considering overall survival also, since we will consider 2006 to the current era of the treatment. Various molecular target, Dr. Satyajit have excellently presented all these molecular targets. So I will briefly discuss about all these. The most common is EGFR, considering, and followed by ELK, ROS, RET, commonly which are we will consider in our clinical practice, and TRK, HER2 fusion, BRAF mutation, and also MET exon 14 mutation we usually do in our clinical practice. So better already Dr. Satyajit have mentioned how to predict the biomarkers. So various modality are FISH, IHC, and RT-PCR. Depends on the availability of the tissue versus the liquid biopsy. So based on 2018 guideline specific, absolute minimum requirement is EGFR, ELK, and ROS1. After the expanded panel, that should include BRAF, MET, RET, HER2, KRAS, and MET exon 14. So current guideline for the neoadjuvant treatment, if patient is stage 1A, no lymph node involvement. So observation after the surgery, no benefit of any adjuvant or neoadjuvant treatment. If patient is 1B or 2A, then the adjuvant treatment, if patient have high risk features, which is size more than 4 centimeter, which was based on the earlier in 2007 HACC, it was 1B, but now it is 2A. So high risk features which are included, the tumor with the poorly differentiated. If tumor is neuroendocrine, then it should be excluded from the risk factor. And another risk factor are vascular invasion, vessel resection, visceral pleural involvement, and unknown lymph node status. In that condition, we will definitely go with the adjuvant treatment after surgery if the lymph node status is unknown. And if patient is exon 19 deletion or exon 21, that L858R mutation, so then we will also consider the osimertinib based adjuvant treatment. And no proven benefit of the neoadjuvant chemotherapy, but recently after approval of the various immunotherapy agents, the atezolizumab and pembrolizumab are approved for the second day onwards, and 2B adjuvant therapy should be included. No addition of benefit of adjuvant radiation in 2B if patient have margin negative and no extracapsular extension. And in 3A or 3B, there are different modalities. Neoadjuvant chemotherapy. Recently, the approval of the immunotherapy is also there. Adjuvant chemotherapy or sequential chemoradiotherapy followed by based on the PACIFIC study. The durvalumab is also used for the patient who have some stage 2B or 3A or 3B after the sequential CTRT treatment. So we have already discussed. So after initial treatment, as we know that most of the patient, the 5-year survival still remains the 40 to 50% of the cancer-free survival. 50 to 60% also recur. So based on these data, there is also need of further treatment lines. So based on this, as we know, already discussed about all these data, that based on the less meta-analysis, the pooled analysis of the 5 trials, which included the approximately 4,500 patients. Most common agent was used cisplatin and vinorelbine. So, which suggests that the improved OS benefit after the adjuvant treatment is 3-year OS benefit was 3.9% and 5.4% at 5 years, based on the less meta-analysis, which include 5 trials. So as we know that if patient is treated with the 1B onwards to 3A, the adjuvant chemotherapy hazard ratio is 0.989. So we should definitely consider if the patient is between the stage 1B to 3A. Stage 1B with high risk features and 2A onwards, we should consider all the patients. So after the ADURA study approval, if the patient who have exon 19 and 21, so in that condition, improved
Sir, your voice is not audible.
it is now possible to further improve survival in the completely resected stage 1, stage 2, and stage 3 non-small cell lung cancer patients. Also, the atezolizumab based also improved the DFS as well as OS in the adjuvant setting if the patient who have PDL1 more than 1%. So, patient at 3 years after the use of the atezolizumab based, the DFS is 60%, and otherwise without use of the atezolizumab, 48.2% was the DFS. Yeah. As we all know that lung cancer radiation, after the recent modalities for the T3, T4 tumor, use of the IMRT based treatment and newer specific treatment line which are used for the radiation therapy are 4D-CT planning and followed by the IGRT based radiation therapy. Also recently the adaptive based radiation therapy have reduced the side effect considering the same outcome of the treatment with the radiation. So end result, if we will use consider the radiation therapy treatment, the smaller target volume for the newer modalities with lower dose to the normal tissue, including the lung and esophagus and heart. So long-term outcome or long-term toxicity can be reduced by using the newer modality of the radiation therapy. Chemotherapy with or without the standard of care after complete resection of the patient with stage 3 lung cancer patients. So in stage 3A and B, chemotherapy or sequential chemotherapy if patient is not an operable candidate, followed by durvalumab, which is PACIFIC trial study based outcome. So as we know that most of the patient in the stage 3 are recurred, followed by the sequential chemoradiotherapy. So considering this point, the PACIFIC trial was done where the one arm which was placebo arm and another arm was considered for the durvalumab based. So earlier it was only flat dose. So now the 10 milligram per kg body weight or 15 for every second weekly and the 15 milligram flat dose for the 4 weekly. Now. Sorry for the interruption. So the durvalumab demonstrated 42.9% overall survival at 5 years in comparison to this historical OS in unresectable stage 3 non-small cell lung cancer. Please. Net चालू है. Sorry for the interruption.
Sir, kindly
So-
conclude your talk, please.
So, hello. Hello.
Yes, sir, you are audible, sir.
Yes, sir, your voice is audible.
So the targeted therapies are improving the outcome in the advanced non-small cell lung cancer. More than approximately 50% of the patients with advanced non-squamous non-small cell lung cancer will have a driver mutation targetable with FDA-approved agent or recently in the various clinical trials. With chemotherapy, the median PFS is 5 to 7 months, while EGFR TKI based the survival is improved from 18.9 months in case of the EGFR positivity. If patient is ALK mutation positive, then the minimum the overall survival is 34.8 months in case of the ALK mutation positive. Survival outcome with various targeted agent in advanced non-small cell lung cancer, as we have already discussed, and Dr. Satyajit and Dr. Nicely
Hello, sir, your voice is not clear.
Sir, your voice is not audible. I think your technical issue.
So the semi
Sir, you can conclude, sir. Satyanarayan, sir, you can conclude your talk also.
Sir, your voice is not available. Can we run from our side? Tech support.
Anyway, I think we can conclude Dr. Satyanarayan's topic.
Okay.
So thank you, Dr. Satyanarayan, sir, for such a elaborate presentation on the overview of the lung cancer. You've extensively covered various key topics related to this complex disease, particularly the current trends, risk factors, the diagnostic methods, and the treatment landscape also. So thank you for your
now
presentation.
I would like to invite Dr. Arpit for the next talk.
Please allow me to share my screen.
Yeah, just wait a minute.
Yeah, okay. I think it is visible and it is in
Yes, it's a
mode
makeup.
also.
Yeah, full screen, sir.
Okay, thank you. So we are through the various aspects of the NSCLC treatment landscape and the diagnostic methods also. Now the final concluding note of this meeting is the real world evidences supporting the role of the osimertinib in first line management of the metastatic NSCLC. So we will start with the landmark FLORA trial. So this is the study schema where they have enrolled good performance status more than 18 years of the patients with locally advanced or metastatic NSCLC who have exon 19 deletion or L858R mutation they must not to be on this prior systemic anti-cancer therapy or any other EGFR TKI therapy. And all those patients who have the stable CNS metastasis were allowed in this study. So they have stratified these patients based on the mutation status, which is exon 19 deletion or L858R. Again, they have stratified these patients based on the racial status also. So they randomized these patients into two arms. One was osimertinib, where they give 80 milligram OD, and the other one was EGF, the comparator EGFR TKI, which could be the gefitinib or the erlotinib. And their primary endpoint was PFS, which was assessed by the investigator, and the secondary endpoints were overall survival, objective response rate, duration of response, and so on. And these were the patient demography. The baseline, they have enrolled around 19% of the patients, they were having the CNS metastasis. In the osimertinib arm, 23% of the patient have CNS metastasis in the EGFR TKI comparator arm. Again, they have all other aspects were also very well matched in both the arms. And if we can see this PFS curve, it again significantly favored the osimertinib arm, where the median PFS was reached to the tune of 18.9 months for the first time in the EGFR mutated NSCLC patients. A median PFS of around 1.5 years could be reached with the use of the osimertinib upfront. While in the EGFR TKI comparator arm, it was only 10.2 with a significant hazard ratio of 0.46. Again, if we can see the forest plot over the right side of this presentation, be it be any subgroup, it could be related to any smoking history or presence or absence of the CNS metastasis, and again, it could be any type of the mutation, could be exon 19 or L858R. All the subsets shows a gain with the use of the osimertinib upfront as compared to the other EGFR TKI. Again, the secondary endpoint was overall survival. It again favors the osimertinib arm, where the median overall survival was reached to the tune of 38.6 as compared to the other EGFR TKI comparator arm with a significant HR of 0.80. Again, this forest plot again favors the osimertinib irrespective of the subgroup of the patient. Similarly, if we can see that the CNS analysis of the FLORA trial, where they shows that these curves are separated since the beginning. So osimertinib shows its effect from the beginning of the initiation of the treatment itself. So osimertinib demonstrated improvement in the CNS PFS also as compared to the EGFR TKI comparator arm, where the median CNS PFS not reached as compared to the EGFR TKI, where it was 13.9. Again, very significant with the HR of 0.48. So with the use of the osimertinib upfront, there is an improvement of the CNS PFS, and it reduces by 52% in the risk of CNS progression. Then again, if we see this, the CNS analysis of the FLORA trial, it shows that cumulative incidence of the CNS progression again favors the osimertinib. So the CNS progression on the osimertinib is favoring to the other EGFR TKI. So these curves are favoring the osimertinib in the first line setting. And if we see very importantly, the safety profile of the osimertinib in the FLORA trial, it shows that any adverse event grade 3 or more than 3 was comparable as compared to the other EGFR TKI agent. So around 42% of the patients, they develop any adverse event grade 3 or more. Similarly, 47% of they had developed with the other EGFR TKI also. Then again, adverse event leading to the death was only 0, while it was 1 in the other EGFR TKI comparator arm. So to conclude the FLORA trial, osimertinib resulted in a significant improvement in the PPFS as compared to the EGFR TKI comparator arm with a significant HR of 0.46. It again shows a significant improvement in the OS also. And it again favors the improvement in the CNS PFS, and also safety profile favors the osimertinib as compared to the other agents. Then after the publication of the FLORA, the questions arises whether these data from the real world these data from the randomized control trial, the results will be reflected in the real world setting or not. So we see that there was an excellent improvement in the OS and PFS, but it could be reflected in the real world setting or not. The question was very pertinent. Then again, the median age group in the FLORA was only 64. So how the osimertinib will did or do in the elderly? It was again a question. Then osimertinib shows a CNS PFS if it would be reflected in the real world setting or not. That was a question. So why these real world studies are important? So definitely the representativeness of the RCTs are not reflected to the real world setting or the patients whom we treat in the clinical practice or not. Definitely. Then again, there is a potential limitations based on the confounding and the bias possibilities also in the real world setting also. Again, generally, the safety and efficacy of the RCTs are very well controlled. While in the real world setting, uh, various other concerns are also needs to be addressed related to the safety particularly. So these were the various real world evidences and the studies. So we will be discussing through this topic one by one, all these topics. So there was a flower study, then the OSIFECT, around 538 patients were there, then the Mykonos, then Spanish, and the HOT 2002 study. So again, they have enrolled, they have assessed the response of the osimertinib in these very pertinent real world parameters or the endpoints, which was time to treatment discontinuation, then then time to treatment failure, and the other one was time to next treatment or the death. So and again PFS was also studied in various studies also. So this is a snapshot where they have compared all the other real world studies in compared to the FLORA. So median PFS as was there in the FLORA, which was 18.9 months, was present or achieved throughout all these real world studies, at least. Then again, median time to treatment discontinuation in the FLORA studies was 25.3 months. Then median time to treatment failure, again 19.1 in the OSIFECT study. Similarly, all other studies also shows that PFS was reached in comparison to the FLORA study. So to begin with, the first study, which is FLOWER, where it was a real-world prospective observational study conducted in various centers of the Italy, where they have given they have enrolled all the metastatic advanced EGFR mutated NSCLC patients, where they treated them in the first line with the osimertinib. And what they found that the partial response and the stable disease was there in 96% of the patients. So clinical benefit rate was around 96%. Again, a progression-free survival was there in 18.9 months. Time to treatment discontinuation was 25.3 months. Again, in line with the landmark FLORA trial. And very importantly, the safety profile, it again favors or was in line with the FLORA trial, where the most common adverse event was skin rashes, paronychia, and diarrhea. And there was no difference in the survival outcome was observed according to the age, comorbidity, and type of the EGFR mutation. So with this real world study, again, the role of the osimertinib was the data was in favor of the osimertinib again. Then comes the OC-FACT study, where it was a retrospective multi-center cohort study conducted at the Japan. Around 538 patients were enrolled. And again, the disease control rate was achieved in 94.1%. And median PFS, again, matching with the landmark FLORA trial to the tune of 20.5 months. Then again, adverse events, pneumonitis grade 3 or less was there in 4.5% of the patients. Similarly, reason for the treatment discontinuation, most commonly it was because of the progression of the disease, which was there in 44% of the patient. And the 16% of the patients, they have developed some kind of the adverse event, most commonly anorexia, skin disorder, and so on. Then comes the third real world study, which was Mykonos. So it was a real world study of the patients with EGFR mutated locally advanced or metastatic NSCLC. They were treated in various centers of the USA, Japan, Germany, and the China. They again enrolled the patients with EGFR 19 deletion in around 51.1% of the patients. Exon 21, particularly L858R mutation, was there in 33.7% of the patients. Some of the patients with uncommon mutations were also enrolled, which was there in around 9.5% of the patients. Again, they have also enrolled some of the patients, they were having a poor performance status. Around 14.4% of the such patients were enrolled. Around 7 patients were those who were having a squamous cell carcinoma histology. Again, very importantly, some of the patients were from the elderly subgroups also. So around 35.2% of the patients were having more than equals to 75 years of the age. Again, what they found is real world time to next treatment of the death again favors the osimertinib. Then it reaches to a tune of 17.9 months. So again, with this real world study, the role of the osimertinib in the first line setting again matures. Then, based on various analysis, it was found that the PFS reached to 16.2 months. Time to treatment discontinuation reaches to the 19.2 months. Time to next treatment or the death was reached to 14.2 months. And again, be any subgroup of the EGFR mutation, all favors the and all shows a improvement in the outcome with the use of the osimertinib in the first line setting. Then comes the Spanish study, which was a retrospective multi-center study. They have enrolled all the confirmed patient with EGFR mutation with particularly exon 19 deletion or the L858R mutation. They have collected and analyzed the data. Around 86 patients were enrolled and their endpoints were PFS and the OS. And they found that median PFS again reaches to 25.9 months. It again confirms the efficacy of the osimertinib in the first line setting. Then the next pertinent question was whether the osimertinib also have a benefit or the role in the elderly population also. So for that, a retrospective multi-center study was conducted with an named as a HOT 2002 at the Japan, where they enrolled around 132% of the 132 patients with a median age of 80 years. So again, more than or around 50% of the patients were more than 80 years of the age. So I think that age group can be found in Japan only. Around 50% of the patients were more than 80 years. And again, now, in such a elderly subgroup also, with the use of the osimertinib, the median PFS of 19.4 months could be reached, which is very astonishing, I can say. Again, median OS was not reached. So with this study, again, the role of the osimertinib matures in particularly in the elderly patients. Then the next meta-analysis or systemic reviews was conducted to found out the role of the osimertinib in the elderly population or not. And it again shows that in line to the FLORA trial, with the use of the osimertinib in the first line setting, in the elderly population also, there was a improvement in the PFS. So if we see these cross-trial comparison with the other landmark trials, which was Lux Lung 7, around 44% of the patients were more than 65 years of the age. In Archer 1050, around 39% of the patients were more than 65 years of the age. And Flora, again, 46% of the patients were elderly. In all these trials, with the use of the EGFR TKI agents in elderly population, it has a improvement in the PFS irrespective also. But again, in toto, the gain of the improvement is favoring the osimertinib only. Then the third important question was that will the improvement in the CNS mets will be reflected in the real world setting or not? So if we see the FLORA trial where the CNS PFS was not reached and again significant as compared to the EGFR TKI comparator, then CNS overall response rate was 66% with the osimertinib, while 43% with the comparator EGFR TKI favors the osimertinib. The similar study or the patient from the China, which was enrolled in the FLORA trial, were again analyzed uh, separately, and they found that around 136% of the patients, they have had a improvement in this, and in among the 136% of the patients with the use of the osimertinib, there was an improvement in the CNS metastasis with the HR of 0.66. Then again, on head-to-head comparison of the various TKI clinical trials, the median PFS again favors the FLORA with a significant median PFS ranges to the tune of 18.9 months. Again, the other comparator arms, they were also excluded the systemic or symptomatic brain metastasis from their subgroups upfront also. Still, FLORA favors the osimertinib in comparison also. Then this meta-analysis was conducted to found out the real world their real world data showing the efficacy of the osimertinib in the CNS metastatic patient also. And it also shows that overall response rate was there in 71% of the patient, disease control rate 93%, and the median PFS of the NSCLC CNS mets with the use of the first line osimertinib reaches to the tune of 12.21 months. So to conclude, again, these recent version of the NCCN guidelines also shows that with the on all the patients with the exon 19 deletion or the L858R mutation, osimertinib remains to be the preferred or category 1 choice, irrespective of the brain metastatic lesion or any patient demography itself. So I would like to conclude and summarize my talk with definitely real world setting also favors osimertinib in the first line setting, as with the data from the randomized control trial itself. Again, osimertinib has demonstrated benefit in the real world constant with the results seen in the FLORA trial. And real world evidences also shows that osimertinib have a edge over the other EGFR TKI in elderly population with the brain metastatic patients and in certain uncommon EGFR TKI patients also. Similarly, we need to have a more emerging real world studies which shows and confirms and the evidences of the osimertinib role in the first line setting itself. So with this, I will conclude my talk on the real world evidences favoring the osimertinib role in the first line setting. So I think we have covered most of the important topics related to the lung cancer management. We have listened the clinical we have listened various speakers, and we have also discussed the role of the various molecular biomarker testing, various other, particularly the osimertinib role in the first line setting. So with this, I would like to conclude this meeting. I would extend my gratitude to all the distinguished speakers, sponsors, and the organizers for their hard work. Thank you for their active participation and dedication. And any other thing needs to be confirmed or?
Okay, thank you so much for the lovely feedback, Dr. Arpit Chen, sir.
Yeah, thank you.
And good night, sir.
Yeah, goodbye, good night.
Technical support